Hello, good evening, everyone. I welcome you all on behalf of Sri Lanka College of Internal Medicine to our second webinar series on advanced diagnostic skills. I cordially invite Dr. Krishanta Jayasagara, President, SLSIM, to address the gathering.
Thank you very much, Sudarshan. Good evening, everyone. It's my pleasure to welcome you all for the Advanced Diagnostic Skills Forum webinar, the second one for the year 2025, where we come together to enhance our expertise as internists and refine our diagnostic acumen. Of course, this forum serves as a platform for knowledge sharing, discussion, and growth, essential elements in our pursuit to excellence in patient care. A special note of appreciation goes to our esteemed speaker today, Dr. Prakash Priyadarshan, for his insightful presentation on advancement in cardiac diagnostics. Dr. Prakash, we sincerely thank you for sharing your time, knowledge, and valuable perspectives with us today. As we move forward to this session, I encourage all participants to engage, post questions, and take full advantage of this opportunity to strengthen your diagnostic skills. Let's continue our commitment to advancement in internal medicine and, most importantly, improving patient outcomes. Thank you, and let's have a productive discussion. Over to you, Dr. Sudarshan, to introduce the speaker and coordinate the session. Over to you, Sudarshan.
Thank you, Dr. Jayasagara, for your kind words. So before proceeding to the lecture, I would like to remind the audience to post your question in Q&A box, and they will be answered at the end. So today's topic is Advancement in Cardiac Imaging by Dr. Prakash Priyadarshan, Consultant Cardiologist, MBBS, MD, MRCP UK, MRCPS Glasgow, FRCP London, FRCP Edinburgh, FCCP, FESC, FEACVI. He has graduated from University of Peradeniya and he obtained his specialized training in cardiac imaging in UK at Bradford and Leeds NHS Trust in all four imaging modalities. He has worked as consultant cardiologist in Ministry of Health at NHSL, DGH Polonnaruwa, DGH Kegol. He is currently working as a consultant cardiologist at Navalaka Hospital PLC, Colombo. He has authored 2 papers and 13 abstracts in international journals. So without further delay, I cordially invite Dr. Prakash to deliver his lecture.
Thank you, Sudarshan, for the kind words. First of all, like to thank Sudarshan and this intervention for inviting me for this prestigious meeting. I didn't expect such a huge audience crowd here. I'm very overwhelmed. Anyway, can you see my screen?
Yes.
Yeah.
Yes, Prakash.
So I think everything fine and we can start. Okay. So this is about current technological imaging strategies. Actually, the imaging strategy is not that current, because cardiac imaging is the world's currently fast growing part in the cardiology, where intervention is still stagnated, but this is going very fast. So what I'm saying is already a little bit older than comparatively older, but for us everything is new. Okay, these also evolving with time. Okay, now let's start. So why this cardiology important is 25% of the global population is South Asian for us, relevant for us, but 60% of the cardiovascular disease we own in the world. And among the 25% of the heart attack, for us, it occurs before the age of 40, and 50% of the population less than 50 years of age. So 40 to 50 is a very high risk in our age group. So we are very, 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 we should be very thorough with our cardiac, especially coronaries. So to make easier, so imaging make easy, because imaging is a large area that I artificially classified into, it is my classification, into coronary artery disease and structural heart disease. And we see first the coronary, how imaging is applicable in the coronary artery disease. So as we know, the coronary disease, the mechanism of attack, everybody knows. This is a atherosclerotic plaque and the plaque formation, and the plaque grows and ultimately rupture and cause the heart attack. But the important thing is identifying the heart attack as correct one, because we lot of misunderstanding of fear mongering diagnosis. Because chest pain is huge, chest wall pain, skin disease, herpes, gastritis, lung problems with the spine, aortic dissection, everything mimic the ischemic heart disease. So, so what the ideal way of diagnosing is doing angiogram, right? Doing angiogram. I think my video is not playing here as usual. Okay, doing angiogram, the ideal way to diagnose. So, but if angiogram, we can look at the coronary artery disease where there are plaques, and definitely we can make, without any further trouble, with angiogram we can make a diagnosis. So ideally is chest pain equal angiogram. Then you can diagnose and treatment. But the problem with angiogram is it is an invasive test. So as we know, it's prone to complications, heart rhythm problems, strokes. During angiogram, patient can get heart attack due to clot formations or bleeding on the bronchocytes, and even death, 0.1% death. So angiogram is not the joke. It can cause complications. And technically also a problem, because no facility to angiogram all our patients, because then everywhere you need cath lab, and cath lab and if you have a cath lab, limited cath lab, you should not use the cath lab to diagnose. You have to treat the patient. That is the time that you have utilized the cath lab. If you try to diagnose, then the cath will be useless and overwhelmed, and it's costly to maintain a cath lab. So angiogram is not the answer to diagnose ischemic heart disease. So we need a very good gatekeeper for ischemic heart disease, which with one test, without wasting time and money, diagnose very quickly. So this gatekeeper should have certain property. That means it should identify ischemia and ischemic area, and it should identify the myocardium, whether it's viable, dead, or working, and it also give the prognosis, and it also give the LV function, what is the remaining LV function. So a gatekeeper should give all the information: ischemia, viability, LV function, and the prognosis. So that is a good gatekeeper. So currently our only gatekeeper is, as you know, famous exercise ECG. Whenever we have chest pain, we do exercise ECG to that patient. So exercise is a good gatekeeper. It's predominantly available in all the hospitals now. Everybody doing exercise ECG for even everything. So very cheap test, easy to perform, very cost-free and ideal for our Sri Lankan setup. But the problem with the exercise ECG is certain population can't be done. As we know, people who can't run, the older people, and certain medical condition like aortic stenosis, and certain ECG changes like left bundle branch block, and WPW syndromes, and LVH, we can't do exercise ECG because it gives a lot of false positive. And the worst part of the exercise ECG is in this slide, because its sensitivity is poor. Its ability to pick up is maximum 70%, and specificity also poor. Even if it says positive or negative, there can be a call of false positive or negative of 30%. This figure is worse with young people. So exercise ECG not the study of choice. So this is further confirmed. Actually, this published in 2010. Can you see NICE guidelines 2010, when I was trained that time? Do not use exercise ECG to diagnose or exclude stable angina for people without known coronary disease. But this is the one we are doing day to day, every day. Doing exercise ECG to diagnose or exclude coronary disease patients. And the ESC guidelines also further you can see it is going against exercise ECG, and more imaging based or CTCA based diagnosis for coronary CTC based diagnosis, for imaging based diagnosis for diagnosing coronary disease. Okay, yeah. Exercise ECG, this is another guideline for ESC guidelines. Exercise ECG is not recommended for diagnostic purpose. Okay, so exercise ECG more or less either UK or NICE guidelines or ESC. Exercise ECG is virtually out. If you go through the ESC guidelines and NICE guidelines, exercise ECG is out. Why this problem? So what can we do? So if we do the ischemic cascade, actually half the blocked blood vessel, there will be poor blood supply to the heart muscle. That is the first thing happens. Then the muscle metabolism changes. Then the heart contraction changes. Initially diastolic dysfunction, then systolic dysfunction. Then only ECG changes appears. Then only angina comes. So you see the cascade. When the patient gives a history of angina, is the last thing. Its sensitivity is extremely poor. Although we are always studying what is that? History is the good marker, but ischemia, actually history is not the good marker. It's the last thing. And the next thing we use is try to diagnose everything with ECG, but even it is a poor diagnostic. Its sensitivity is so low. It comes at the last end of the ischemic cascade, not at the beginning. So that is the way the imaging developed. So it's developed the bridge the vacuum, seeing is believing. So there are four important non-invasive modalities: cardiac CT, cardiac MRI, advanced echo, and nuclear cardiology, involving PETs and PET and SPECT. Okay, how they blocked? The blocked blood vessel pick up by CT coronary angiogram non-invasively. Of course, angiogram is invasive. And poor blood supply pick up by the SPECT perfusion scan, or CMR also has perfusion scan, or now there's echo perfusion scan. And the metabolic problems started to occur, pick up by the PET scan. And the contraction, of course, picked by the stress echo or stress CMR, or wall motion, abnormality picked up by these at the stress. And ECG appears, this is where our exercise ECG stands, this is where history stands to pick up the ischemic heart disease. So these modalities are far superior and picking up the ischemia at the early onset. So let's have a quick look at a CT coronary angiogram. Mind you, this is not an extensive lecture on CT angiogram. I just touched through how CT works. Okay. So CT angiogram. Unfortunately, all my videos are not working, so I'm going without videos. Okay. So now this is our CT room, and you can see very easy test. When the patient comes, we are given a beta blocker. Then we inject the contrast through the cannula in the hand, very small amount, about 60 ml. Then the scan takes 2 to 3 seconds. Faster is 2.75 seconds. You can do a scan and take the patient out. And you can see this pretty picture. You can see this pretty pictures of coronary artery disease in 3 dimensions, and you can analyze the coronary artery disease. And currently, technology is so improved. Now you can see a very clear picture here. You can see the coronary artery. This is my previous CT. This is my current CT machine. You can see a pretty edge-enhanced view of the coronary artery disease. And CT coronary angiogram definitely show the blocks. Can you see? After CT, you can see the blocks. So CT is very quick. This is the first instance, immediately picking up the coronary artery disease and very sensitive. Sorry about it. And here, this is another picture of CT picking up the vessels. Okay. This is also okay. Right. Now, CT not only is picking up the vessels, CT also pick up the lesions. Very sensitive. Now look at the current machines. Even a tiny speck of plaque, even sometimes overlooked by the invasive coronary angiogram. We do invasive coronary angiogram, these type of plaques are at the wall, and you tend to see very overlook these things. Okay, even CT picks up and highlight those very tiny plaques. Okay, and it can do a vessel diameter analysis, and not only that, the current CTs even can analyze the plaque morphology. Why plaque morphology is important? You can do only stenosis, that's enough. If you have 60% or more than 70% stenosis, you can stent. 50% less than 50% stenosis, you can leave it alone. Why the plaque morphology? Because we know the plaques are made up of 3 layers, three compositions. One is the lipid core, and the fibrosis, and the calcium. Those are 3 main components of a plaque. More the lipid core, easier the plaque will rupture. So even a less than 50% plaque can rupture and cause acute coronary syndrome. If it is if the fibrous cap is thin and the lipid burden is small. So CT, current day CT, it can be only diagnosed by invasively during either you can do IVUS, intravascular ultrasound, or OCT. But here now CT non-invasively can pick up this vulnerable plaques or plaques that rupture. Here, this is a picture of analysis. Here, this can give color code to the red, blue, and yellow code, whether it's fibrotic plaque, calcified plaque, or lipid core. Okay, so these can even here this machine is searching for the you can analyze, you can search for the abnormal plaques. Here, this machine picked up the abnormal plaque. Here, this plaque has a huge calcific burden because of the white yellowish color, and the lumen is turned to green color, and a little bit of fibrosis, and the red color is the lipid core. This lipid core is very less in the plaque. So this is a more or less a strong, stable plaque, not a vulnerable plaque. So can you see this is not only picking up the lesion stenosis. Now these are not very magic things. It's one click, these will analyze very quickly by the machine. So you can see the vulnerability of plaque. Here, another plaque lesion. Can you see the calcium deposited all over the place? And you can see a fibrotic plaque here, and the fibrotic plaque and the cholesterol plaque. These are the very sensitive plaques which can cause rupture. So CT will give stenosis and even the morphology. And what CT do more is a stent analysis. Previously, there was a myth that CT can't analyze stent. True, because CT, this calcium, this metal can cause a blooming artifact. That means it blooms out. Then the lumen can't be seen properly. Here, the current technology, current advances in CT makes the lumen is very clear. Can you see the lumen? The stent was implanted, and this is the calcification of the original plaque. The stent is pushing the plaque. Here, the original plaque is pushed by the stent and staying outside, and you can see the lumens very clearly with the current machines. Okay, and even it helped the analysis the stents also, stent length, stent in 3D views. You can analyze the stent and you can analyze the lesion and plan your procedure even before you take the patient to the cath lab. And bypass analysis. What is important bypass analysis? Here, CT comes in a long way. The reason is previously we do coronary angiograms. Now the guideline says if the patient is having a bypass, you have to do CT first before take the patient to the cath lab. Why CT first and before then take the cath lab is the principle is in cath lab, if you do the angiogram, you have to search for this vessel single one by one. Native vessels, very easy to search because from the second MBBS, we know the anatomy. We know which coronary sinus the right coronary is there and which coronary sinus the left coronary is there. You can put a catheter and you can easily engage and inject the dye. But bypass, it is complete done by the surgeon's wish. Surgeon put wherever he want. Here, this surgeon has put all these graphs here. This surgeon is put in order. So when you try to search, a lot of time you're spending inside the cath lab. There's a lot of radiation. While searching, you inject a lot of contrast. So a lot of contrast. Furthermore, when you're moving the catheter a long time, the aortic root atheromas can dislodge and can cause stroke. So bypass angiograms are always more riskier than the native vessel angiograms. So that is what CT scores very easily. Because at one shot, CT can completely show, this is my older machine, this is my new machine. And CT shows complete the coronary tree very quickly. And even the lesions, even the coronary bypass and even the lesions. Then we go for the intervention. All the normal coronaries, you don't need to search. You can straight away go for the selected, whichever the bypass that is blocked, then straight away engage, and one shot you can put a stent and come back. So cath lab is used for stenting procedure. So CTs pre-analyze the bypass graph before send for the cath lab. So CT comes always the first before the invasive coronary angiogram if the patient has an unstable angina or stable angina with the bypass. Okay, and this is one of the current other development in CT where it shows the hybrid imaging. What is hybrid imaging? You can know the nuclear cardiology shows ischemia. We all know nuclear cardiology shows ischemia. CT shows blocks. So you merge both these pictures. This is now very common. Most of the cardiology service merging, fusing images. We can fuse the echo to the cath lab, echo to the cath lab. Similarly, here CT can fuse the SPECT. So here there's a coronary artery. Here there is a block. And if you merge the SPECT, here you can see the ischemia. So at one shot, you can give wealth of information. You can know the coronary arteries. you know the area of ischemia, you know the ischemic area, you know this is the vulnerable area that you have tackled, then you can plan and do the procedure. So with one screening, you can get plenty of information if you merge the hybrid image. But CT team, now the cardiology, there are 4 teams, each rival to other people. So CT team don't like to merge with SPECT team, nuclear team. So they develop their own perfusion scan, own perfusion. This is their own myocardial perfusion. This is currently in our machine, although we are doing very little studies because of the time it takes. Here you can you can do a plain study where the contrast is completely covering. Then the same study you repeat with the stress. Then suddenly you see a perfusion defect in the myocardium. The CT will pick up and give the graph and see the ischemic area, and you can plot in the bullseye and you see the ischemic area. So here the same study you can do with using the contrast without stress, and you can give contrast after stress, adenosine stress or something, any stress. Then you can do the same CT again, and you can get 2 information. One, not only the coronary arteries, amount of contrast that go into the myocardium. Then you can plot and find out before stress and after stress and find the ischemic area. So that is a perfusion. So CT will show not only the blocks, this gives the myocardial perfusion. This is very important, myocardial perfusion in cardiology. Why? If you have a tight block, you know this has to be stented. If you know more than 70%, if you know less than 50% lesion, we know it should be medically managed. The doubt comes about 70 to 50%. So what are we going to do? Are we going to stent, or just stent, or are we going to just leave it alone? So this is a doubtful gray area. So perfusion scan comes handy. So if you do a perfusion scan, if the perfusion is well maintained in spite of a 60% lesion or 70% lesion, that can be leave it alone and manage medically. If the perfusion scan comes very poor, then you know even this patient, that 60% lesion is significant. So scientifically you can prove and you can stent. Okay. So by adding CT and the perfusion scan together, you can give multiple information. You can see the lesion stenosis and the lesion significance, whether lesion has to be treated or we can leave it alone. So this can't be done in exercise ECG. So it's a multimodality things. Now the current you will hear this very soon that CT FFR. FFR is a kind of a study that because that study we can do contrast 2 times. So there's a lot of contrast. One is stress and one is rest. Here a technology called CT FFR. The same thing, same study, a computer algorithm picks up the amount of the contrast and give value. According to the contrast, this computer algorithm give values. So if the value is less than 85%, then you know it's a stenosis. Okay. So here these values are good and these values are poor. So there's ischemia. After the lesion, there's ischemia. So one shot you can do a CT, and same thing you do CT FFR. But you have to understand the CT FFR is a technologically very, very, very demanding and very expensive. And it's normally the companies never now selling the software. We have to send our data after doing a CT. We send we upload, and company will give the report because they don't want to sell the program. So it's quite expensive to pay. So we are not doing it. Doing this CT perfusion is easy, but this is expensive. We are not doing it. Okay. And this is the current advance in CT, that preemptive diagnosis. What is preemptive diagnosis? That is, even a tiny plaque, the CT can now do a perivascular inflammation study. If you do a CT, simple CT, then the small software will show perivascular inflammation. If you see a perivascular inflammation, this area will cause a vulnerable plaque, and soon there will be thrombus formation will come, even if it is a tiny plaque. So this detecting the perivascular inflammation is a game changer. It is very, very new, And at present, this software we are trying to get into our machine incorporate, but still the company promise not given us yet. Okay, so this is preemptive diagnosis. So CT can show not only coronary disease, it can analyze the plaque, it can analyze the peri-inflammation, and it can analyze the perfusion also. So CT become a one-stop test. Okay. Now, this organizers asked me about the CT calcium score. This calcium score, they want calcium score more or less an obsolete test these days. The reason is previously calcium score is very, very high on the card because calcium score, the radiation dose is very low. Very low. It is around 2 to 3 millisieverts, where the CT show 24 millisieverts. But the current technology with the 640 slice CT and the technological development, CT also comes to the radiation dose of only 2 to 3 millisieverts. So there's no difference between the radiation dose, whether you ask for calcium score or CT, only thing the contrast. It's non-contrast, there's a contrast. Okay. So the calcium score is, and I want to emphasize this thing. A lot of people still, I frequently see calcium score, they think it is in the lab. It's not, I'm not joking or anything, it's serious misunderstanding about the calcium score. But calcium score is a study of a CT machine, and you can analyze the amount of calcium in the plaque. This does not show the stenotic severity. It only shows the probability of a significant lesion. That is the thing that you have to understand. So if the score comes as 0, the probability of ischemic event is less than 5%, very, very low. If it is up to 10, it is still very low, less than 10%. So up to 100, it is kind of a mild significant. 100 to 400 comes as moderate significant. Okay, most likely it's mild plaque. There is a possibility there is a significant plaque up to 100 to 400. Above 400, there's a high chance there is a significant plaque. You know, the word chance is a probability scan. So if we have more than 400, the probability of you having significant plaque is high. That doesn't mean you have a plaque. The probability is high. Okay. So then you can take, according to the clinical picture, you can take a decision and see the calcium score definitely show where the plaque burden is. Here the LAD has 53, RC has 10, circumflex has 1, total 64. This is less than 100. So it is mild. Category falls into category mild. Okay. So you can decide your strategy according to the calcium score. Okay. So this is how the calcium score scored. We go through the CT machine and get the amount of calcium inside the heart, inside the coronary artery, then calculate the calcium score. Right. And sorry about it, again, my video is not working in this new computer. And again, this CT can also shows, now the next final question is, can CT assess the LV function? Yes, CT can. CT can perfectly analyze the LV function, left ventricular ejection fraction, far more accurately, because edge tracing is very accurate. So LV function can be assessed CT. Even not only LV, it calculates the volumes of the left atrium. Now, currently, left atrium is the most important, becoming a most important chamber in cardiology. So it analyzes left atrium and other chambers also. So CT almost comes as a one-stop area. It comes LV function and including ischemia and the perfusion, everything. And one final call, the CT, this is the old soup, okay? That is, CT has the ability to pick up triple rule out. The 3 diseases that kill a patient in acute ET, emergency unit, is one is coronary disease, second one is pulmonary embolism, other one is aortic dissection. So if patients come with severe chest pain in the ET, these are the 3 things that you have to exclude immediately, whether it's having pulmonary embolism, or he's having an aortic dissection, or he's having a coronary disease. CT as a package, CT at one CT scan, you can get all 3. This is called triple rule out therapy. So if you in the ET, if you have any suspicion, you can pick up the pulmonary embolism, this is aortic dissection, and the pulmonary embolism and the coronary disease in a one single scan, one single contrast. So after that, you don't need to bother too much. Even the other 2 emergencies also inadvertently pick up by the esophageal rupture, and the pneumothorax also inadvertently come. But these are the cardinal three, the CT targets with contrast. Okay, so is CT a very useful tool in the ET, emergency unit, if you have any doubt, rather than waiting for diagnose pulmonary embolism and aortic dissection, or asking only for pulmonary embolism protocol or only for the coronary, you can ask all three. You can ask all three. The technician can modify and do all three in one go. You can exclude embolism, dissection, and ischemic arteries at one go. So that is the easiest thing. Easiest, if you know, you can order these tests easily. Okay, so CT in a coronary patients, okay, normally CT is used as an exclusion test. Exclusion test means you need an exclusion test very accurately, because if you know the young people coming to a clinic with chest pain, lot of people have a label of unstable angina, where you can't find anything, troponin is negative, label as unstable angina. Rest of the life they are taking coronary. Peripheral physicians know that their clinic is full with unstable angina labeled diagnosed patients, which you can't chase them also. They will keep on coming. Cardiology will chase the patient to periphery, and periphery consultants suffer. So CT is the way out. If you see a CT, if it is non-invasive, safe, you can exclude these patients are non-cardiac chest pain. And diabetic patients nowadays, currently CT is coming in just like during the proteinuria. Diabetic patients, CT, there's a big trial is going on doing CT for diabetic patient to pick up coronary disease early. And other things are for interventional cardiologists, where difficult angiogram, CT is the way forward, and the bypass graft, CT is the way forward. Okay, so coronary disease, CT will help you in this manner. Now I'll move a little bit to cardiac MRI. Okay, so a little bit of cardiac MRI. MRI also a big machine. We all know, big machine with the big magnet, and it is used either 3 Tesla, 1.5 Tesla. Mainly all the physicians love 3 Tesla, but cardiologists love 1.5 Tesla, because most of the cardiac work can be done in 1.5 Tesla. And this is the big magnet where you send the patient in and magnetize his body and give a radio frequency and change his magnetic potential. So you can get pretty pictures, magnetic pictures. Okay, so this is again my videos are not working. Okay, fine. So you can see a pretty picture here, like this very, very crystal clear myocardium. You can see a thinned out myocardium. Can you see thinned out dead myocardium, and a dilated cardiomyopathy with dilated muscle, thin dead areas of apex, and you can diagnose. So CT, MRI give pretty pictures, and LV volumes you can easily analyze. So it's LV volumes just like CT, but CT is involving radiation contrast. MRI is no contrast. You can give LV volumes very accurately, LV measurements. Then again, now next, what is the next thing that I have to do? Whether it can do a perfusion study. Yes, MRI can do perfusion study. That means ischemic area. Just now we study CT can do ischemia by giving contrast twice and compare. Similarly, MRI can, while giving the gadolinium, you can see the perfusion. Here this study, they are giving the gadolinium, and you can see there's a perfusion defect coming here. Later on, if you leave it more than a certain amount of time, that will be filled off. That will be quickly filled off, and you won't see after that. So initially, within few, while the contrast is going, if you look carefully, you can see a perfusion defect. So MRI this is called ischemia. So you can do two things. Either you can do, so you can, while giving the contrast, you can do an ischemic study also with the MRI. So MRI can do ischemia. And furthermore, one step more to CT, MRI can pick up the dead muscles or damaged muscles. So here, this whitish scar is a scar tissue. So MRI can a little bit of more better than CT in imaging. The thing is, CT can pick up perfusion only or ischemia. MRI can pick up ischemia as well as the dead muscle, or viable, we call it viability. Okay, so MRI is helped by here. This muscle is non-viable. Why is non-viable? Whole myocardium is white, so apex is dead. We know it's elevated territory ischemic injury. Here you can see ischemic injury only at the on the epicardial territory. Epicardial territory only dead. Rest of the myocardium is normal. This is viability. this is a very, very important sign in MRI because ischemia is always affects the endocardial side. Endocardium is the one affected by ischemia. So ischemic injury always starts from inside and go out. So this is a clearly and lateral wall ischemia. By the circ ischemia, this can cause this type of ischemia, circumflex territory. Okay. So MRI used for mainly for viability, it can use muscle ischemia, it can use LV function, it can use. But what we get referrals to, people who fear contrast come and do coronary artery with why can't you do a CT? Why can't you do a MRI coronary angiogram? Yes, MRI coronary angiogram can be done. It's a very good in pediatrics we do. In adults, we also have a software they incorporated, but it is time consuming. Its accuracy is very difficult. A small measurement error can a lot of problems. Why? Because MRI is slow. If the patient is tachycardia, the heart coronary arteries move very fast. MRI is slow. It's very cumbersome study where CT is very fast. CT is while the heart rate is going up. Even our machine scans on even 100 beats, it will scan without any issue. Normally say 60. So then you can see a very quick picture. But MRI angiogram can be done. We are not doing it. It's not practical, although we have the package to do it. So MRI also can say viability, ischemia, left ventricular function, but coronary artery diagnosis very difficult. I still see referrals for coronary artery by MRI. Then echocardiogram. Then the third modality for cardiac imaging for coronary artery disease is echocardiogram. So echocardiogram is the modality that we already know, which we can go quickly, do ultrasound scan, and these are the three pictures. We can get the ultrasound pictures, and we can see these beautiful pictures from the MRI. Now, what I want to highlight in the echo is now not only LV function, now echo team also try to match the MRI and the CT. So echo team develop a contrast echo. What they do is now we can give a contrast, echo contrast, echo contrast, special echo contrast made up of albumin bubbles. So inject, then the echo's problem is the edges are sometimes not clear, especially apex. That is where echo's accuracies go below MRI. But when you inject the contrast, can you see the complete LV volume, the bullet-shaped LV volume comes perfectly nice. So now the measurements are equal to MRI. That is a trial proven. If you give the contrast, rather than asking for LV volumes from MRI, LV volume, I want to study the ejection fraction by MRI, you can get the ejection fraction similar to MRI if you use a contrast. So that is the new development. Even at the peripheral hospital, you can, if you have echo machine, you can use a contrast and get the very accurate LV volume measurements. Similarly, a poor man's perfusion scan, a poor man's ischemia study. Here, MRI can do it. Same thing. You do a echo, then you do inject the contrast. The echo contrast will fill the myocardium and the cavity. Then there's a thing called flash. Flash is high frequency ultrasound. You give a flash, it completely breaks down all the contrast bubbles, all the bubbles. But the cavity bubble will again refill very quickly because you're injecting continuously. Cavity bubble will refill quickly, and then you can see slowly myocardium fill where the blood supply is very good. So failure ischemia means here you can see a black area filling the contrast very slowly. So it's poor man's ischemic study. You do echo, you do a contrast, bubble contrast, and you do a flash and see where the ischemia is. So it is even done at any echo room where a patient has suspected ischemia, LV function is normal, give a perfusion, then you can study. You can study a quick perfusion study and see where the ischemia is. Very simple and effective tool. And the unfortunate message comes is our government, our health ministry still not approved this bubble contrast. So we are still not purchasing it. If you purchase it, it's a very simple and effective tool. Okay. Then of course we all should know The other one is stress. The most simple and easy is stress echo. And we can do two types of stress echoes. The principle behind the stress echo is, if you know the wall motion abnormality, you know when ischemia comes, wall motion abnormality happens. First of all, ischemia, then the metabolic defect, then the wall motion abnormalities comes. Okay. So by using the exercise or dobutamine, adenosine, various stress, this image is not working. So you can see the wall motion abnormalities. Right? When you give the ischemia, suddenly, if the LA territory, anterior wall won't work. Anterior wall won't work. Okay. So echo, that is the easiest and very effective method if your patient can't afford. If your patient can't afford, and if you are not happy with the exercise ECG, exercise echo or dobutamine stress echo, if they can't run, is the most easiest and accurate poor man's ischemic study. That totally depends on the ischemia. So that is a poor man's ischemic study is a stress echo. Even any hospital can start the stress echo service or dobutamine stress echo service if you're cautious. Okay. And echo also, I do 3D, this 3D echo, get the 3D volumes. And there's always, you heard about strain imaging. What is strain imaging is, echo now has a strain imaging. What is strain imaging is, echo can pick up how much each segment of this dot, you can see this called speckles. How much each speckle is expanding and relaxing, so that it can pick up the wall motion abnormalities even before your eye sees. Even before your eye sees, normally we are eyeballing and saying this is the wall motion abnormalities. Strain imaging pick up this speckle movement and pick the wall motion abnormalities very easily and give a strain score. Here there's a good contraction relaxation and partial contraction relaxation. So you can pick up even very early. If you add strain imaging or tissue imaging, your wall motion abnormality diagnosis will be very, very easy. So these are echo room technology. So these all help us to do a non-invasive test very quickly. And echo also can use viability because of the stress echo, and LV function ischemia also can assert, we know. And finally, the nuclear imaging. What is nuclear imaging? Nuclear imaging is also also all these big machines. I'm playing with these big machines. This is also big machine. And there are two types. One is SPECT and the one is PET. SPECT scan or PET scan. The SPECT scan deal with blood supply. SPECT scan deal with metabolism. PET scan deal with metabolism. We'll go through. So you can use either thallium or technetium as a radioactive substance, and you can see a pretty picture here. When thallium goes into the myocardium, it brightens the myocardium, and myocardium looks beautifully lighten up and show beautifully. This is a lateral wall septum, anterior wall, inferior wall, and the donut cut. You can see beautiful. If it is ischemia, you can see, can you see at the rest level, the bright, beautifully bright thallium. After ischemia, there's no thallium is coming to the stressed area. So there's no bright, no gamma, no radiation from here. So you can see whole here. So it is very, very sensitive for ischemia. And here again, resting beautifully full, stress giving a wall motion ischemic defect. So you know anterior wall is ischemia, right? And here this is a good picture, last picture. Rest, there's a gap. Stress also there's a gap. So both are gap. What does that mean? This is already dead and gone. There's no ischemia and no muscle. So this is viability. You can see the dead muscle. So this is the SPECT scan. Very, very simple scan that we are doing it. Still people think that Sri Lanka, we are not doing it. We are doing it jolly well, but predominantly in the private sector. National Hospital also doing their service, but predominantly in the private sector. Okay. So this is the SPECT. SPECT scan also can analyze LV volumes. This is a 3D SPECT where it can get the LV volumes. Although my Magaski, my video is not working, but it also can cause LV volumes. Okay. Then this is now. How about PET? Now PET is something different. SPECT is doing along the blood supply. PET is going through the muscle metabolism. So you use metabolic substance like sugar, ammonia, water, and tag with the radioactive substance, and you can send. But the pictures are same. Here, highly metabolic active FTG PET with sugar, everything is bright, 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 bright. Exactly spec-like pictures. But if you do ischemia here, this patient is having ischemia in this area, but metabolic study shows well lightened up metabolic. So this is not dead. This is still living. So metabolic activity is still maintained. So PET give a good viability study and good ischemic study also. So SPECT and SPECT also can apply same thing like that. If you can't do exercise ECG, you can go for stress echo for ischemia. You can go for or nuclear scan for ischemia. And because nuclear scan not depend on ECGs, you can see the blocks easily, see the ischemia. Especially in intervention cardiologists have a problem when they have 70% block. They want the ischemia induced by the imaging modalities. Either they use echo, stress echo imaging and see the wall motion abnormality, or nuclear scan imaging, so wall motion perfusion defect, not exercise ECG. Exercise ECG is a poor ischemic diagnostic tool. Okay, so this is how our 3-4 imaging modalities used in the coronary disease. This is the most important part and the largest part that a general physician who deals with day-to-day life, real-life patients, not like cardiologists. We see only selective patients. So you deal with the real-life patients when the doubt is more and the differential diagnosis is very broad. And these 4 modalities help to distinguish your ischemic from non-ischemic. You can pick and choose. And what is structural use? The structural use is, why I put this is, people always think structural disease is done by MRI or echo. No. Structural disease can be done by CT as well. CT structural disease now going in a bound. Suppose for few examples I told you, these are the video. TAVI assessment, transaortic valve replacement, TAVI, is completely depends on CT to assess the aorta. So we all know CT always has aorta. What is surprising in it? But not now. CT has surpassed that, because now not only TAVI planning, CT for aortic stent planning, and CT for infective endocarditis also now. If you can't echo, if your echo images are very poor, you do TOE. But if you TOE also can't be done all the patient, do a CT. CT will show you a valve very clearly, and even the vegetations. So not MRI. MRI is very difficult, too slow. Valves move very fast. MRI can't be seen. People think MRI is superior to CT. MRI is superior. I show you later in what content, but vegetation valve is too fast for CT, MRI. So vegetation, if your echo TOE can't be done, TOE contraindicated, get a CT and get an infective endocarditis and paravalvular abscess sorted out. Okay, that's quick. This is TAVI planning, and and this is a endocarditis here. This is an endocarditis picture pick up by the CT during the patient with endocarditis. Okay, so CT goes a long way, picking up with a lot of structural heart diseases, especially coronary sign assessment for pacemaker, pacemaker implantment, and congenital heart disease where patient is struggling, not cooperating with the MRI. CT is the easiest way forward, because currently radiation dose is very less. And if CT do everything, what MRI? Is only the radiation is the one separate CT and MRI? No. MRI has its own potential in structural heart disease. Why it is own potential? Because MRI is only modality. This is the distinguishing features from MRI to CT to echo to every other modalities, because it is a virtue. It gives you a virtual histology, because it completely characterizes the fat, edema, scar, muscle, and iron. By looking at this myocardium, if you identify these tissue, you know the diagnosis. For an example, you would have seen dilated heart. EF is low. Easy diagnosis, ischemic heart disease. 2 diagnoses only, mainly we make. Even I also make. What is the first diagnosis? EF is low, poor LV function, ischemic heart disease, or cardiomyopathy. That is 2 diagnoses we always make. But if you do MRI, you'll be surprised that plenty of diagnoses will pop up. Here, you can see the top image, okay, here dilated heart. Here the patient has a dilated heart, okay, LV. But if you do a CT, the scar is, if you look at the scar is endocardial, scar is no scar. The scar, white color scar is only at the epicardial region. Epicardial, can you see? I told you in ischemia only cause endocardial scar and then full thickness scar, not starting from the outside to in. So this is a myocarditis. So very common, frequently we miss myocarditis, troponin positive, ischemia, chest pain, troponin positive, LV dilated, ischemia. But actually it is myocarditis. And here, another, this, can you see, this is ischemic. Here, can you see endocardial? This is the dilated heart. You do here full thickness white color dead, and here endocardial surface is scarred. So this is ischemic cardiomyopathy. This is myocarditis causing dilated heart. Both are troponin positive dilated heart. So CMR, this is the power of CMR compared to other studies. And look at even the other hypertrophic cardiomyopathy. Everything is HOCM or hypertension. Two diagnoses we always make is hypertension or HOCM. But if you do a CMR, you can do surprisingly new things. You can see here patchy scars. Here, patchy scars. This is the sarcoidosis. Sarcoidosis cardiac involvement. Here, scar along the ring-like endocardial surface, but it is not the ischemic area. Never ischemia comes like this. See all the territory, RCA, LCX, LA, no single territory, completely cover the endocardium. This is amyloidosis. Amyloidosis causing LV hypertrophy. In the elderly people, we always think it's hypertension. So that is where MRI helps. If you have a suspicion about the LVH, if the echo report comes with LVH, if you have any suspicious, think outside the box and do MRI. That will pick up the actual pathology. And even the HOCM, even the hypertrophic cardiomyopathy, not all the hypertrophic cardiomyopathy will be dead because most people living fine without any HCM, hypertrophic cardiomyopathy without non-obstructive, okay? But you can see the scar burden. Here, this is the scar in the septal of the HCM. These people have very high risk of sudden death due to VT. So if a HOCM patient, you can say, I diagnosed HOCM, family history is HOCM, I am very happy, no need for extra investigation is wrong. We have to do a MRI to find what is the arrhythmic risk, what is the risk of sudden cardiac death. So MRI will reveal the scar burden. If the scar burden reaches 15%, sudden cardiac death is very, very high. Okay, and finally the echo, the 3D echoes. The people always ask 2D echo, but 3D echoes come for 2D echoes always for structural heart disease, pediatrics or adult. The 3D echo structural heart disease mainly comes with valve assessment. Here, mitral valve assessment, 3D echoes gives a pretty picture. Here, prosthetic valve assessment. I'm very sad the videos are not playing, but these are beautiful pictures of a prosthetic valve by simple transesophageal echo. You can see the paravalvular leak, the two leaflets are closing, everything can be seen very easily, right? So that is the power of 3D echo. Then how nuclear scan help the structural heart disease? Again, nuclear scan can cause metabolism. We study perfusion, ischemia, but structural heart disease, suppose you have a suspected endocarditis, infective endocarditis, you struggling to diagnose, your echo is not, can't find the vegetation, and your TO is not working, CT is picking up a non-specific thing, then you want to see the inflammatory area, do a nuclear scan of the heart. Nuclear scan will always go and brighten up here around the prosthetic valve, around the valve here. This is brighten up saying there is endocarditis, this inflammation is going here. This is the aortic valve endocarditis, the paravalvular abscess. Here, beautifully activate and show you. So nuclear scan help you. Nuclear cardiac scan, in case if you can't, not only the ischemia, it picks up the inflammation also. Not only that, Takayasu arteritis. Here, Takayasu arteritis, you know the aorta, CT shows dilated aorta, you don't know whether this inflammation is there or not. Do a nuclear scan. It shows the inflammation of the aorta. Then your diagnosis is made. So cardiology, all these, not only ischemia, these all three modalities help you to diagnose structural heart disease also. Okay, and this is one of the few advancement what is this is autonomic function assessment. What is autonomic function nuclear scan helps is, suppose you have a heart failure patient. Heart failure patient dies due to two reasons. One is they die of heart failure, or they die of VT. Those are two: sudden cardiac death due to VT or heart failure deaths. So heart failure deaths go with the amount of the adrenaline receptors on the top, adrenaline receptor. So that is picked by the MIBG scan spect. So if a MIBG spec shows defects, various MIBG defects with late, then you know this patient's risk is very high for VT. VT risk is high. In spite of they are normal, they are living nicely, they are running around. Normally people mock. Echo says 20% ejection fraction. These guys are running all over the place, but they die suddenly. They won't come to the clinic suddenly because VT will come. So those risks will pick up by the MIBG scans. Okay, and finally, how nuclear scan diagnosis. If you don't have an MRI, even if MRI, you know MRI diagnose amyloidosis, but AL amyloidosis or ATTR amyloidosis it won't, because that distinction is very important. Because AL amyloidosis is a medical emergency because it's cancer, blood dysplasia. But ATTR amyloidosis is a totally different ball of game. Then that ATTR amyloidosis diagnosed by nuclear scan. If you see hypertrophic myocardium, if your CMR says amyloidosis, go for nuclear scan for the heart. Then it will show how nuclear activity. If the nuclear activity is equal, it is actually bone scan. PYP used for bone scan. If the nuclear activity is equal to the bone, there's no amyloid. Here, slightly increased, moderate, grade 3. Here, lot of activity in the heart than the bone. So this is high activity of PYP. So this is the ATTR amyloid. So your amyloid diagnosis is pretty straightforward. Not biopsy. Biopsy is the most difficult and non-accurate thing. You can easily diagnose by history and the echo, then do the MRI and do ATTR scan. Then you know it is ATTR amyloid. So these are the broad areas the nuclear scan, the cardiac imaging covers can help you diagnose the coronary disease or structural heart disease. And there are a lot more to discuss about the analysis of things and everything. And I can show you. If the time is right, the presentation is still more. But I asked Dr. Sudarshan if you want to moderate, then, or shall I continue? Or
you can continue.
Okay, so this is just for scientific purposes. Okay, we know the structural and the ischemic heart disease. Our coronary imaging is nuclear cardiac imaging is a great area for simple analysis. Okay. Why this gatekeeper investigation superior is, I told you several times. It pick up the dead muscles are viable. It pick up the LV function. It pick up the ischemic muscles, and it gives the prognosis. Okay, so these are the three things. But in spite of that, there are pitfalls. Now pitfalls is, I know all of you are going to ask is, one is accuracy of the test, cost effectiveness. This is what the question that Dr. Sudarshan want to ask me, and the radiation dose and the contrast usage. This is common question. I also keep every day patients ask these questions from me. Okay. For accuracy for the imaging technique here, sensitivity of a stress ECG is, I told you, very poor. SPECT scan is good, stress echo is good, CT angio look sensitivity and specificity, and the stress CMR is also very good. So they all are above 80, but stress exercise ECG is not that great in picking up coronary disease. Okay, and this is one of the trial shows. Actually, the trial, some of the slides are missing. They found out that adding exercise ECG or nuclear scan, your clinical diagnostic accuracy goes markedly high, predictability markedly high, and you add, not only depend on the exercise ECG alone, if you add the imaging modality. That is what current European guidelines clearly says. Imaging ischemia has to be diagnosed by imaging modalities, whatever the imaging modality, either nuclear, CT or MRI, use imaging modalities because two things, because its accuracy of picking up the disease is very high, right? And the radiation safety. Okay, so this is the standard radiation. You get 3 millisieverts in typical background radiation. In all, it is American data, and 50 millisieverts is the lowest cancer risk radiation dose. Okay, but chest X-ray is 0.1. This is wrong. Now we are this a little older. These are the radiation dose of NBC. CT is 1 to 1.3, and SPECT is 0.5. Definitely, X-ray is very, very low. But these are now low, more than low. Data is a little bit old, but even SPECT has come down dramatically. So this is the radiation dose, and it's far less than the cutoff point approved by the new atomic energy authority. Okay, and the contrast safety is two things. One is whether contrast cause the allergic reactions or contrast causing the nephropathy. Okay. Okay, so the mortality rate due to the use of radio contrast media due to allergy is very, very low. 1.5 events per allergy, but serious is very, very low contrast allergy. And the radiation contrast nephropathy is also very low. Very low, because normal nephropathy comes to about 100 cc, but we are using about 50 to 60 cc of contrast for each study. So it's not even very low. So for information, during the PCI, we use a lot. We use almost 200, 300 cc contrast to a stent in a multi-vessel stenting. But here, comparatively, very low. Not even 50 cc. You can finish 50 to 60 cc. You can finish a complete study, especially bypass study. It's very, very beneficial. And the allergic risk is very low. Even death is very low. And the cost effectiveness, of course, wow, cost effectiveness. How can you argue for the cost effectiveness? Is single study. These studies are very expensive. If you study a CT, if you want to study a CT, in my hospital, it is CT cost you around 60,000. It's quite expensive for a poor person. 60,000. The government hospital do free of charge. Okay, but if you give overall, if you use the imaging as a gatekeeper, it prevents unnecessary downstream testing. If you do rather than exercise is very cost effective, but it prevents. What are the prevents? It reduces the need for downstream testing. Okay, and is it quickly risk stratified and treat only the needed patients. Okay, and only needed patients goes to the cath lab. So cath lab is not burdened. So unnecessary cath lab workload will go down. Unnecessary normal angiograms never come to the cath lab. Cath lab used for treatment purposes. So the waiting list for the PCI stenting, the patient are dying for that, will be reduced because you already know the viability, ischemia. So cath lab can be used only for the treatment purposes. So you can effectively use and downstream test, unnecessary medication. You all know, if a patient labeled as unstable angina, rest of the life he is going to come to the clinic, government clinic, and take medication. Come to the rest of the life, he is going to take ischemic medication, and he take leave. So young people take leave and come to stop their work and come to the clinics. The clinics are a burden and wastage of money, wastage of drugs. So if on the top, if you keep a very accurate testing procedure on the top of the apex, then you can completely cut down the downstream wastage of unnecessary cath lab procedure, unnecessary medications, and the high quality care. The people who need most, not all the people who come. Suppose 70% lesion can come and get a stent, where a 70% with an ischemic person not get a stent. So you can classify the patient whom you treat and what you treat even before come to the cath lab if you are apex procedure. And these procedures cost can be come down. Its cost depends on number. If the numbers are more, suppose in National Hospital, if you have a machine, if the numbers are more, per patient cost come down very, very drastically low. The numbers are less, only the cost is high. Okay. So there are trials which I'm skipping. Okay. Here the guideline says, low risk people exercise ECG don't do. intermediate risk go for nucleus imaging-based scan, and low risk CT and high risk angiogram directly. So if the ischemic risk is very low, CT angiogram; ischemic is very high, invasive angiogram. That is the rule of thumb for all the European guidelines as well as the NICE guidelines. Okay, thank you very much.
Thank you, Dr. Prakash Priyadarshan, for this excellent and eye-opening lecture. I think I learned a lot, so I think the participants also must have gained a lot. So please post your questions in the Q&A box. So I will, shall I read the Q&A, Dr. Prakash?
Yeah, sure, no.
So the first one, when you mean CT can be used to exclude coronary artery disease in patients labeled with unstable angina, is that a CT coronary angio?
Yeah, of course, of course. Sorry, I'm a cardiologist. When I mention CT, it is only CT coronary. Yeah, CT coronary. If this all the guideline is pre-test probability. This is the doctor-driven. You have to make a call. If you think a pre-test probability is low, a young female who is very active, working in the village very actively, comes with the chest pain, and the pre-test for family history is not there, then if she come with chest pain, we immediately treat as unstable. You do a troponin. The troponin ECG, some subtle changes in the T inversions in the anterior lead, very subtle T inversion. Immediate diagnosis, we labeled as unstable angina. That is the easiest labeling. But then that label goes on forever. No, if you do a CT, then that's time you can easily distinguish whether. So you have to call the pre-test probability. Same thing, a patient, high risk patient, a diabetic patient who is coming with chest pain, definitely CT has no place because your pre-test probably clearly says this patient is having ischemic heart disease. So no point in beating around the bush and doing CT. Straight away go for angiogram. So you are the person who triaging this patient. If you have a doubt in between, yes, this patient has diabetic, this patient has hypertension, this patient is smoker, his pre-test probability is high, but this angina is wishy-washy, this is not, can't be seen as a true ischemia, then you do a functional assessment like stress echo, nucleus scan, where dobutamine stress echo, where imaging base is induced ischemia. If the ischemia is induced, you are very happy. This is ischemic heart disease. If ischemia is not induced, you can manage, treat the risk factors, not ischemic heart disease. Okay, it's a coronary disease, not ischemic heart disease. So that is how the guideline says. CT at one end, exclusion study. Invasive angiogram is an inclusion study. In between, functional assessment is helpful.
Okay, thank you. So the next question, how useful that CT, MRI, PET assessing the vegetation texture, healing, friable, prone to get embolization, can PET pick up metabolically active vegetation and differentiate between active and healing vegetation?
Yeah, this is a very good question because this all depends on the sizes. CT will pick up very small, very small vegetation also CT can pick up. And CT still we are using CT. Suppose for an example, if you have a friable mobile vegetation in the in the aortic valve, okay, suspected aortic valve, and we don't know, it may not be a vegetation, okay. Then if the patient, if it's not healing, if we go to surgery, okay, nobody will do an angiogram on that patient because this will embolize definitely. So those are times CT do dual work. It will diagnose the CT and it do the angiogram also. So surgeon can straight away go for surgery without depending on the coronary angiogram. The CT is very accurate. Yeah, metabolic activity and healing activity also can pick by PET. But you should have, there's a special protocols to do that. And we do very few in, I am doing the PET SPECT in Lanka Hospital. PET is too costly and number of patients are coming is less. So Sri Lanka, we are not doing PET as it is, but yes, metabolically active, dormant, it can pick up.
The next one, can the above investigation help in deciding the need or timing of the valve replacement in infective endocarditis? I think you have already answered. No? Yeah. So the next one, which specialty analyze the CT coronary angiogram in the government sector, cardiology or radiology?
You are trying to create a problem. Luckily, I am in the private sector. Yes, it is like this. Honest, it is honest opinion. I am not a cardiologist nor radiologist. It is like my view. Okay, this in other countries, cardiologists and radiologists both do CT. Cardiologist, radiologists both do CT, but unfortunately, wherever I went for training is all completely cardiology dominant places, and the radiologist also more or less dedicated to cardiac imaging. They don't do ultrasound abdomen and then come and do. They do dedicated cardiologists because there is a thing called clinical sense. Clinical imaging. There are certain questions the interventional cardiologist asks. So that if you ask, you have to be with the cardiologist. You have to know where landing zone of a stent, how the stent is reacting, whether the branches treatment get blocked with that. So there are a lot of tiny techniques. Stenotic area is very important with 70%. So those things, if you be with the cardiologist, very easy to interpret, easy to tell your cardiology colleagues. So technically, cardiologist is best. If the radiologist is doing, they should be a dedicated cardioradiologist.
Okay.
Then there's no discrimination. Then the clinical question, because these you can't have a second thought. If you make a missed call, it's end up in death or complications. So you can't give a much of a missed call. So better to be either a cardiology or immaterial, somebody who dedicated into that field. Yes.
Yeah, okay, thank you. The next question. As a GP, how we refer patient for CT coronary angiogram? He didn't mention whether it's in the private sector or government sector. So can you just answer for both in case? Yeah.
Yeah, government sector, of course. Government sector is currently, I think, outside reference, the government national hospital is only doing imaging. Private sector is multiple centers have started now. All the my hospitals started first. Now a lot of other hospitals also doing. But the government sector, if you want to refer, I think better you have to refer to a consultant working in national hospital. He is the national hospital or consultant. Your consultant has to refer for the CT, and they refer to the radiology department of the NHS. They give the date. And they will do the CT free of charge in the government sector. But that is government sector. Private sector is a different kettle of fish. You can write a consultant that you like. There are a lot of consultants doing CT. You can write the consultant you like, write their name, and write that you want a CT. Okay, then it's pretty easy. Then that consultant will take a total responsibility and do the CTs and the patient here.
Okay, thank you. So the next one, what is the best imaging for detecting high risk plaque? CT, CA or invasive CA or SPECT?
Right. High risk plaque is high risk plaque means we call thin fibroatheroma, thin cap fibroatheroma, TF. Okay, that means a plaque which has a plaque as I told you, three component: a fibrotic component, lipid component, and the calcium component. Normally, okay. If the covering is very thin and the lipid core is very large, then that plaque will rupture anytime. So that is called high risk plaque or vulnerable plaque. So picking up this plaque, coronary angiogram definitely can't identify the high risk plaque. Coronary angiogram is a stenotic, only stenosis. It shows 30%, 50%, 60%. It can't pick up the vulnerability of the plaque, whether this plaque is high risk plaque, non-risk plaque. For that, they use invasive imaging. They use IVS or OCT, invasive imaging to see the plaques. But if you want to see non-invasive, the high risk plaques can be easily diagnosed by CT. CT is the easiest. Okay. Or else Sometimes now the new Oxford studies, now they are doing PET, not SPECT, PET. PET to see the activity of the plaque, coronary activity of the plaque. If the plaque is metabolically active, then the chance this plaque will rupture more, because the macrophages and the metalloproteinases are active. So then this plaque is up. It's very cumbersome, very difficult study, where CT one scan you can see everything. Okay, but PET is not SPECT. PET can be used or CT can be used. In cath lab, you are doing invasive imaging, IVS or CT.
Okay. Thank you, Dr. Prakash. So I think that's the just one more question. What is the time taken to do the CTCA and exclude pulmonary embolism and dissection as a ACS as in ACS time is muscle? So it's not clear. I think the
No, I can understand the question. His question is, you do a CT, takes a lot of time. Time
yeah.
is muscle. But rather than sending to cath lab, wasting time in CT. Yeah, that's a good question. This is totally depends on your hospital protocol. Your hospital protocol and how willing your radiology department works. Because this won't take much time at all. The patient comes, putting a cannula, giving him a bed, and inject, and within 3 seconds, 5 seconds, both will be scanned. Because initially, when the dye is going into the pulmonary artery, first scan will happen to exclude pulmonary embolism. When the dye comes to the aorta, the second scan will happen to pick up the aortic dissection in the coronary arteries. Okay, 2 scans simultaneously work within few seconds. So timing of the scan is not an issue at all. The time is the protocol of the hospital, whether how quickly you can take a patient from the emergency unit to the radiology department or the CT department and get your CT done. If the CT is fully occupied, if they don't give date, if they give a time slot, here there is no time slot. Time slot, cardiology should not have a time slot. If the time slot is the issue, then you are going to be in trouble. Then and there, they should stop the list and do this protocol. So that is what technically private sector is easy. You can stop any list and you can do it.
Okay, right. So I think that's all the questions. And once again, I thank Dr. Prakash Priyadarshan for delivering this wonderful lecture to us amidst your commitments and your precious time in this junction. So thank you everyone for joining, and good night, and have a pleasant evening. Thank you, Dr. Prakash.
Thank you very much. Thank you.